During the ESMO 2023, we presented the results of a phase 3 global randomized MARIPOSA-2 trial. The MARIPOSA-2 trial including patients with advanced non-small cell lung cancer harboring EGFR mutation after progression of osimertinib. There was a randomized to receive amivantamab plus chemotherapy, carboplatin pemetrexed, with or without lazertinib compared to standard chemotherapy. The resistant mechanism after osimertinib are very diverse and polyclonal, with up to half being related to EGFR and MET alteration. In this particular setting, there are no target therapy approach, and the outcome with the platinum-based chemotherapy very poor. The ambition of the MARIPOSA-2 trial was to evaluate the combination of amivantamab plus chemotherapy or amivantamab plus chemotherapy with or without lazertinib in patients that are progressing after osimertinib in clinical setting. The MARIPOSA-2 is a randomized phase 3 trial including patients from Asia, European countries and United States, and we enrolled 657 patients progressing on or after osimertinib. Stratification factor was a line of therapy with osimertinib, was race, and also present brain metastasis. Present brain metastases were allowed, and definitely radiotherapy was not required for all the patients. In the trial, the primary endpoint was the progression-free survival by blind independent central review for ami chemo versus chemo, and for ami chemo with lazertinib versus chemo. The main results of the MARIPOSA-2 was the study met both the primary endpoint. We had an improvement, a statistically significant improvement for progression-free survival for amivantamab plus chemotherapy, and both for amivantamab chemo with lazertinib, with an hazard ratio of 0.44 and 0.48, with a reduction in risk of disease progression and death by 52% and 56% respectively. This data was impressive also when we confirm the over-response rate among the three arms. For patients that received the combination with amivantamab plus chemotherapy, the response rate was higher than 60%, confirmed also in the other arms, so ami, chemo, lazertinib, compared to the only 36% for those patients that receive chemotherapy alone. Interestingly, in our study, we showed that the combination of amivantamab plus chemotherapy with or without lazertinib showed a statistically significant improvement in intracranial progression-free survival with an hazard ratio of less than 0.50 for both the arms. This was very interesting with or without the addition of tyrosine kinase inhibitors, confirming a significant brain protection for the addiction of amivantamab in this particular setting. And this data was also confirmed for patients that showed the brain metastasis at the beginning of the study and did not receive definitive radiotherapy. Globally, the safety confirmed, of course, that those patients that receive the combo with amivantamab showed, of course, toxicity related on EGFR and MET pathway, and a high number of patients showed anemia and thrombocytopenia that was clearly related to chemotherapy block. Generally, this kind of toxicity came back in the first cycle and was not dose limiting. VTE, ILD was very low, and number of deaths related to toxicity was similar across the three arms. Evaluating overall data that we presented today, the combination of amivantamab plus chemotherapy should be considered the new standard of care for all patients with advanced non-small cell lung cancer that are progressing on or after osimertinib. This is important to consider, balancing the efficacy, the safety, and also the intracranial progression-free survival that are the key results for this kind of trial.